Welcome to this month's What's New on Embodia webinar. Do we need to find a new language for pain? Practical ideas to optimize communication in your clinic. Joining us today is this month's esteemed guest, physiotherapist, researcher, lecturer, and internationally recognized educator, Mike Stewart. Mike's no pain workshops have provided clinicians around the world with practical pain education skills, and that's just what he will do today. Today, Mike will help us explore optimizing communication strategies in your clinical practice. You'll leave with practical, evidence-informed tools to shift how you talk about, there you go, and treat pain with your patients. We also have Maggie Bergeron, Embodia's co-founder and CEO, to discuss new features and tools on Embodia. And me, Natalia, Embodia's client relations and content manager, and I'll be giving you a few tips on two-way messaging on Embodia. If you have any questions anytime during the webinar, please feel free to drop them in the Q&A, and we'll do our best to get to all of them either during our talk or after. Now, little disclaimer, due to the amount of great content that we'll be covering today, this session will actually run closer to 45 minutes instead of the originally planned 30. We promise it will be worth your while. Can't stay for the whole session? That is okay. There are a couple of ways to catch the replay, either on the live stream on Embodia's YouTube channel or in this free course where all webinars in the series are posted. We will also be giving away one free seat to Mike Stewart's upcoming weekend course on Embodia, a practical guide for persistent pain therapy, the November 2025 edition, which is a $399 value. One lucky live attendee will win the prize, and we'll play in a fun game during the webinar to decide which of you will take that prize home today. We'd also like to remind you that Embodia now offers AI charting and that all Embodia practice management users get the first 10 hours of this feature free to test it out. If you've tried it or have been using it, we'd love to hear about how it's been going for you. Another piece of exciting news, we are thrilled to announce that Embodia is now a CEU-approved provider for PTs and PTAs in 35 US states, as well as the US Virgin Islands. That means that very soon, many courses in Embodia will offer CEUs for PTs and PTAs in the US. We'll have more information about this in the coming weeks. All right, so for those of you joining us today who might be a little bit less familiar with Embodia, a little bit about us first. Embodia is an all-in-one practice solution offering a complete practice management system with built-in HEP, offering a growing library of 2,000 plus high-definition exercise videos with voiceovers and print-friendly versions, billing and reporting, charting, scheduling and online booking, outcome measures and questionnaires, telerehab, practitioner continuing education, and more. You also have the option to add a clinic academy to any of our paid memberships.
Oh, looks like we've lost Natalia.
Also have the when you get started with Embodia or any navigate Embodia and set up your clinic the exact way that you wish. These guides include our 30-minute step-by-step onboarding video with instructions to help you set up your clinic.
I think Natalia is having some internet issues, so I'm going to pause it here and we'll just switch over to Mike, who's going to share with us some helpful tips on communicating with patients in the clinic.
Thanks, Maggie. Thanks, Natalia. Hi, my name's Mike Stewart. I'm a physiotherapist from the United Kingdom. Let me start by sharing the webinar that I have that we're going to talk about today. The title of which is, Do We Need to Find a New Language for Pain? I'll give you a spoiler alert. The answer, I think, is yes. Practical ideas to optimize communication in your clinic. So what I'm going to try and do today in this short period of time is highlight some problems that we have with communication and language within healthcare. and then also look at some solutions, because the problem isn't the problem, the solution is the problem, as I'm constantly getting across to my patients and students. So, first of all, a little bit about me. I'm Mike Stewart. I'm a physiotherapist from the UK. I've been a physio for 30 years, helping people to make sense of their pain experiences through individual groups, sessions, class sessions. Then the second job that I have is teaching. I've taught in 24 different countries around the world. And if you thought that pain was a bit weird, you should try teaching in 24 countries, because it gets even weirder each time you cross any border. And then the third job that I have is research. So my research interests involve language, communication, education, particularly how can we develop better skills in those areas to help our patients best. So that's a bit about me. I think if we're going to answer this question, do we need to find a new language for pain? The first thing we have to do is deal with this question: what is pain? And I think it's really important to sort of get this across to you all and to patients, that our understanding of pain has changed dramatically in a very short period of time. If we look from Mountcastle in 1980 to Lorimer Moseley in 2003, in the grand scheme of the universe, this is a very, very small space of time, but a huge 180-degree shift in our understanding about what pain is. And I know lots of us, lots of clinicians who are watching this at the moment, we get this. We understand that pain is not linked to damage and harm, that pain is linked to your perception of threat, to how you view the world. But patients are often playing catch up here. And I think the media and the rest of society are also playing catch up with this, which is where we start to get into some problems with regards to how we talk and how we think about pain. So, if we start to think about pain being related to perceived threat, this saber-toothed tiger as represented here, then we start to sort of see some problems that we have regularly appearing in clinic. I'll give you an example. I had a patient called Ben, a really talented 400-meter sprinter. He wants to go to the Olympic Games, win gold medals. That's his dream in life. But when Ben came to see me, he had knee pain with a lot of anxiety. So I said to Ben, what's the thing that's sort of bugging you? You know, what's keeping you awake at 3:30 in the morning? What's stopping you from sleeping? And he brought into me a booklet. It was an educational booklet that had been given to him by his physiotherapist. This is a small extract from that booklet. You can find it at this link here. Now, I want to point out that this is not me pointing a finger at his physiotherapist. The physical therapist that he'd seen had done a perfectly good job. I think often we threaten patients, we make their situation worse, not better, without realizing that we're doing this. So when Ben came in to see me with this anxiety, he said it was these words particularly that were making him so anxious: disc herniation, epidural injections, surgery, disc injury. He said at the end of the process, when we'd helped him, he felt broken when he was looking back and reflecting. He couldn't switch off the thought that he was going to need surgery. So constantly 3:30, 4:30 in the morning, he's sitting in this nest of fears and just in this soup of anxiety, and things just kept getting worse. His knee pain kept getting worse and worse. And this fits very nicely with Eccleston and Crombez, who beautifully put it as pain is an ideal habitat for worry to flourish. Now, as I say, the physical therapist who'd given him this booklet had not intended to make Ben's situation worse, but we often do. We often pour fertilizer onto pain's worrying ground without realizing that we're doing it. It's very, very easy to do. And this is why we need to highlight the importance of this today and give you some solutions. Just to make it more interesting, when I said to Ben, is there anything else that was worrying you? What sort of was the trigger? What was the catalyst for your concern? He introduced me to this. This was a poster. This poster was on the the athletics club room corridor. So when Ben was going to his athletics club, this poster, which was created by a doctor who worked for UK Athletics, was created to try and make people like Ben seek help. but it's making the problem worse. Get that niggle checked or your dreams could be wrecked. See your UK athletics doctor or physio promptly if you're not sure why something hurts. It could save your season. I mean, look, this is a scary looking, as Lau and Pentagura say, a nocebo, placebo's evil twin. I always get across to patients, are you happy with the term placebo? And they'll say, oh, yeah, it's where you take that sugar pill and you feel magically better or whatever. So they have a sort of mild understanding of what placebo is, but often they've never heard of the term nocebo. Nocebo is placebo's evil twin. Pain is a gig where the devil plays all the best tunes. You're looking for threat information. And sadly, this is what Ben was on the receiving end of. This poster also fits very nicely with this study by Demova and colleagues produced at Cambridge University. I'm sure maybe some of you watching this webinar have experienced neuropathic pain yourself, perhaps, or maybe perhaps you've met a patient who's had neuropathic pain. Either way, neuropathic pain is not pleasant. You do not want to experience neuropathic pain. So it's fascinating to bear in mind that they induced neuropathic-like sensitivity in perfectly healthy people, people like Ben, young kids who are running on a track and sort of living life to the full. You can induce neuropathic-like sensitivity with pessimism, showing people scary posters like this, pointing people towards the dark side, even without us realizing that we're doing it. This is not a new problem. This is an old problem that we've never really got to grips with. As you can see here, Rudyard Kipling said these words to the Royal College of Surgeons in London in 1923. So just over 100 years ago, he said this to surgeons: words are, of course, the most powerful drug used by mankind. He went on to say this: like drugs, words have the ability to change the way another person thinks and feels. So whenever we're saying something to a patient, something that's meaningless to us, doesn't contain any threat, perhaps, then we have to consider this, that words are like drugs. And this works both ways. We sit in a pivotal role. We can either shift people towards hope and optimism, positivity, or hurt and harm and negativity and threat, all those things that we know are linked to pain experiences. This confirms something to me as well. We often play a game with our patients, and you can try this yourself. Words are like toothpaste. Once you squeeze the toothpaste out of the tube, it's impossible to put the toothpaste back in again. I don't know about you, but in my clinic, I seem to spend a lot of time trying to put back in the toothpaste that's been, poured out by a doctor who said something in 5 seconds without realizing the threat of that one word, spondylolisthesis, perhaps. So I think we've got to consider that. We have to accept the fact that once these words are out there in the consciousness, it's there. We've then got to pick up those pieces. We can also play another game. In psychology, there's a chicken game. I'm sure you would all like to play the chicken game. I would like you to try as hard as you possibly can, whatever you do. Do not think about a chicken wearing a Mexican sombrero hat. Game over. As soon as I've highlighted the idea of a chicken wearing a Mexican sombrero hat, the game is over. I'm sure none of you have ever thought about this before. Maybe you have. But now you can't get it out of your head. And this is no different to that word, Schmall's node on an MRI scan in a lumbar spine, perhaps. I like to play games with patients, and I think this is one of the sort of practical tools that you can take forward is to give people experiences rather than information. Have some fun with experiences rather than being dry with literal information, facts and figures, those sorts of things. It tends to stick much better with people. So with that in mind, I'm sure some of you who are watching like cats. I like cats. I'm sure lots of other people do. Those of you who like cats will know instantly what this cat wants. This is a game we play with our patients. You can too. I can share these slides. Look at this cat. This cat, what does this cat want? And when we do this with patients, some patients will say, this looks like a really hungry cat. Yeah, you got it. This is a good cat person. You're connecting well with the cat. This, of course, is the hungry cat. But what about this cat? What does this cat want? Look at these big, soft, playful eyes. What does that cat want? Now, all of a sudden, we've got another patient who's saying, oh, this is the cat that really wants a cuddle, the soft and happy, playful cat. If you're freaking out at this point, don't worry, it's exactly the same cat. If I'm hungry, the cat's hungry. If I want to cuddle, the cat wants a cuddle. But what if, when I was 7 years of age, I went to my friend's birthday party and a cat that looked just like this scratched my face without any warning whatsoever? Of course, this cat is now this cat. Die, human slave. This is the sinister menace cat who's going to sort of, rip my eyeball out of its socket. And this comes in very neatly into a bit of philosophy that we have to start considering here. The Talmud says this: we don't see things the way they are, we see things the way we are. Again, if I'm hungry, the cat's hungry. But equally, if I've had a negative past experience with this cat, then I'm going to see it in a threatening situation. This is no different to bending when you're trying to pick up your shoes and socks. I see people all the time, they stop bending, their wife puts their shoes and socks on because they become fearful. There's a fear avoidant behavior. People are not distressed by things, they're distressed by their view of things. It's not the bending that's the issue. I often get across to patients that if you're 45 years of age and you've had back pain for 5 years, prior to that 5 years, you had 40 years of positive bending experiences, playing with your friends in the park, doing all sorts of things that were working well. So it's trying to shift that perception because, as we know, if we can change perception, we can change pain, we can change the experience of pain. Why is this so crucial to think about the words that we use? Well, this study sort of confirms something that we already knew, really. Barker and colleagues did a study where they looked at the same words that we use as clinicians and how that same word is interpreted by the patient. So let's have a look at these four things and let's play a game yourself with this. Chronic. What do we mean by the word chronic as a clinician? I'm sure the first thing you start to think of is time. Most clinicians will say more than a few months. What does that same word, the exact same word, mean to a patient? Something very different. 2 steps from a wheelchair. So chronic for us equals time, chronic for them equals severe. So this is maybe where the word persistent might be better. The pain will persist for a while, but it may get better. Instability. It's okay, John, you've got some instability in your shoulder. I'm going to give you some TheraBand exercises. Of course, John is now sitting there thinking, well, I'm not going to do some strengthening exercises. I'm going to wrap myself up in cotton wool and protect myself here. Or wear and tear. Rather than saying to people, Jean, you're 55 years of age, you have some wear and tear in your knee. I'm not going to use the term chronic degenerative knee disease. Probably wear and tear is better, we might think. But of course, these terms, these metaphors can have their own problems. Something is rotting away. We see this idea of rotten fruit, rotten vegetables through different studies. Barker and colleagues found it here, but Deborah Padfield and colleagues found it visually with photography. They said to people, if your pain was a photograph, what would it look like? And we found rotten fruit, rotten vegetables. Neurological, death within 6 months, could be a tumor. I once did this with a group of patients. I did the same thing. I said, neurological, what does this mean? And at the same time, I held up a reflex hammer. And one of my patients said, pancreatic cancer. Not just cancer, but pancreatic cancer. So, of course, I asked him, why pancreatic cancer? And he said, well, I was watching the TV program. There's like a TV hospital drama program. And the doctor diagnosed the pancreatic cancer holding one of those things that you have in your hand. So you can see how people make these leaps. As we've said, pain is the gig where the devil plays all the best tunes. You're looking for threat information to confirm your perception of the world. So what might we need to start to do? I wrote an article with a colleague of mine, Stephen Loftus, and we suggested in this article that we need to think about two things. when we're using language with patients or when we're meeting people who've been told other things by other colleagues, what does it all mean to them? And how can we help them to find a positive meaning in this situation? How can we shift that focus towards something much more hopeful? And this is a big thing. This is a big social thing, psychological, biological, cultural, philosophical. And maybe it starts with just a simple understanding that, as we've said, some of these words we do need to start avoiding. These are the toothpaste that's squeezed out of the tube. And again, I mean, often patients have heard these things already. Chronic degenerative changes. I often make a bit of fun with this, but I'll say to my patients, if they say, I've got chronic degenerative changes in my discs, in my back, I'll say, oh, I'm really sorry to hear that, but I understand how you feel because I have a chronic degenerative disease too. I have chronic degenerative hair disease. Of course, we don't call this chronic degenerative hair disease. This is normalized as going bald, getting older. And then what do? We either accept it and move on with life, or we don't and we try and find a wig or something, or. So we can start to think about acceptance and commitment through these ideas. So a lot of words that maybe we need to think about shifting and maybe moving towards the right-hand side. Some of these green words, things that are a little bit more positive and hopeful for people. If we're thinking about communication do's and don'ts, some tips and ideas to take away with you from today. This comes from Louis Gifford's work and the psychologist Steve Linton's work. Communication is the most vital skill in our toolkit. We do need to join with patients, go off topic. I once had a patient years ago who said to me, my hairdresser makes a better communicator than any of you physios. I said, why? And she said, well, whenever I go to get my hair cut, they don't begin the conversation by asking, how has your hair been since I last saw you? But of course, in healthcare, we do it all the time. How's your shoulder been? How's your neck been? How's your back been? We don't see them as a human. They're a piece of anatomy. And that's no surprise because we spend so long focusing on anatomy and biomechanics and pathology. Attend to what you say and how you say it. Small things make big differences. So lots of non-verbal communication cues can have a big impact. Where your hands are, where your arms are your arms crossed? Are they open? Are you warm and welcoming? Are you pointing your finger? We see this a lot. We do research where we video and audio record clinicians, particularly physiotherapists with patients. We see a lot of finger pointing. We know if you look at the evidence in business, in politics, finger pointing is a big no-no. You lose people by pointing your finger. But in healthcare, we see it a lot, particularly in physiotherapy. It's quite a paternalistic thing. So small things make big differences. You can say a lot without saying any words at all. Develop a shared understanding, informal chat. Some of the best conversations that I ever look at in clinical practice look like two friends in a cafe. I often refer to it as Bob Marley therapy. It's warm, it's welcoming, it's professional, but at the same time, it's not sort of formulaic recipe-based stuff. Prompt sensitive information, show empathy, show acceptance. Look, I think this is really important. Don't provide opportunities for misinterpretations of ambiguous information. Ambiguity sits at the heart of healthcare communication. We've seen this already with the different words that people take. This is all to do with ambiguity. So we've got to be certain that the patient is on the same page. So we've got to check and check again. Don't succumb to that the pressure of a structural diagnosis, having to think to people, you've got to say that it's coming from this first place. Also, don't jump in those first 2 minutes. Start the conversation with, how can I help? And then get good at zipping it. I sort of will constantly do this with patients. How can I help? Tell me about what's been going on. And then they'll start to talk and they'll say something that's really interesting. And I'm dying to burst in, but I'm constantly saying to myself for the first couple of minutes, shut up, Mike. Shut up, Mike. Be quiet, Mike. Because they've got stuff that's going on here and they need 2 minutes to get it out. Just not the whole narrative, just the pertinent narrative. Another one thing I'm going to pick up here, don't miss opportunities to capture issues that require perceptual change. This is especially important when patients use metaphors. One of the things that we teach is the idea that patients use metaphors all the time. They will say to you that I feel like I've hit rock bottom, that I've fallen off a cliff edge. There's lots of different words and terms that people will use. We've got to get better at being able to capture those moments and use the patient's own metaphor as a window into how can we help them? How can we understand and shift their understanding of the world? We know that pain is often described in very simple terms. I wrote in this book chapter that people often say ouch as the way to describe it, but there's much more going on underneath the surface. And really, maybe a better word for pain is the word distress. If I say to a group of physio students, what have you got in your armory to help people with pain? They'll say exercise therapy, manual therapy, electrotherapy. Okay, now, what have you got in your armory, in your toolkit to help people with distress? That same group of physio students will often say, that's not my job, that's a psychologist's job. But I think we're wrong because distress is intrinsically linked to the experience of pain. So, with that in mind, if your friend was distressed, I'm sure lots of you would sit like this. You would go to a cafe, there would be a lot of eye contact, and you would talk like this. Bloody hell, that sounds terrible. I'm so sorry to hear that. How have you been? You would talk as a human being to another human being, to a friend, to a loved one. But there's a problem with this because when we're trained to be a clinician, we know the evidence shows that often we lose this sense of ourself, of this natural communication style, like we would talk to a friend or a loved one. So instead, we end up, first of all, not looking at our friend. Eye contact reduces because we're now looking at the screen and we're documenting and maybe taking notes. And then, of course, we change the way we talk. So we'll say things like this. Okay, so your partner's left you for the gym instructor. How does that make you feel on a scale of 0 to 10? I'm trying to be amusing, but you can see the friend is likely to be a bit less amused, I would have thought. So I'm going to just finish off with some top tips, just 3 sort of situations that you might commonly find yourself in if you find that you don't have enough time to really listen and that you're struggling to sort of make that time. Do make the most of it. Allow them uninterrupted to talk for that first couple of minutes. The evidence backs this up beautifully, that giving people that first 2 minutes is crucial. Acknowledge the constraints that we have. We only have this much time together today. What's the thing that we really need to focus in on here? So sort of hone in on those things. Use blended learning. In education, we're not allowed to use the term homework. We often think of it as negative connotation. So blended learning, think of blended learning, stuff that you do together in the clinic, stuff that you can do apart separately. Here's some things to look at. And what I'll often do is say to people, look, here's a video on YouTube to go and watch if that's your thing. When you come back next time, write down 2 lists for me. What made sense? What didn't make sense? So we've got a sort of somewhere to go next time based on their observations and reflections here. What do we do if we're finding it hard to pay attention? Well, some obvious things. Dedicate time to listen to their story. That's the central thing. That's what we're paid to do, is to listen to them. Remove distractions. Remove all those things that might get in the way of providing that therapeutic rapport and alliance. Make eye contact. As one of my patients once said to me, oh, thank God you're not using tick boxology, which he meant, going through those motions, going through those tick boxes on the form. So making sure that eye contact is the predominant thing that you're concentrating on. Confirm, play things back. This sounds dreadful. Can I just check that I've got this right? You've just said that you haven't slept for 3 weeks and that you've not been able to play with your daughter. Is that correct? So going back through things, we can often forget to do these things. And finally, if we're finding it difficult not to jump in and find solutions for their problem, often as physios, we like to try and fix people and try and get people out of a sticky situation, then be aware. Don't assume that we're on the same page. Check, clarify things. Think about these 3 rules. Listen, then find out what they want, who they are, where they're at, and then finally guide them. I think healthcare communication and education works so much better if you follow that simple 1, 2, 3. Listen, find out what they want, guide them. Don't tell them, guide them. Act like a signposter. I hope that's been helpful. One more thing. Scott Dempster and colleagues suggested that we need to shift from this fix it mindset to a sit with it mindset. And this is crucially important because we found throughout the literature that one of the biggest compelling barriers to physical therapists helping their patients is our desire to fix and treat. It stops us from getting in, it gets in the way of being able to help people. It's counterintuitive. So make sure that you're sitting with it. Listen to the story rather than trying to fix the problem. Here are the references, some of the work that I've been doing of late with these wonderful people here and here, and some references that we've covered today, plus a few more. So I do hope that's been really helpful. Thank you so much. And maybe we have some questions at the end. I'm going to hand back to Maggie for now.
Yeah, thank you so much, Mike. That was so helpful. I wonder if well, there's a few comments here in the Q&A section. Thinking about all the medical posters and images of disc bulges and tissue issues hanging in PT clinics. So more of a comment there.
Yeah, do you know, I'm just going to jump in there. I recently taught at an NHS hospital here in the UK, and they were giving out little booklets to patients in the waiting room, and it was all about cauda equina syndrome. And big red scary warnings, cauda equina, if you lose your bladder and bowel control, and if we do this. Now, that's a real problem because you're switching people on to a potential worry that's very, very rare, and of course there is a balance to be met here. We do need to tell people about these things, but when are we causing harm over helping people? I think this is an important factor to consider.
Angela has a question here in the chat. For the chatty patients, how do you transition into your treatment session if they don't give up the floor and keep talking? And when do you start implementing it?
Yeah, I think that's really important. Sometimes we do get people who just want to chat and go off topic. I think it's a skill in a sense to be that diplomatic sort of person who's able to steer the conversation like you would with a friend in the pub. This is interesting, but how does this relate to this? So it's all about diplomatically, without feeling like you're sort of ruling the conversation, being able to steer where that conversation goes. Um, I think it's important to allow people to chat to some extent. I find colleagues of mine will often say, how did you discover this, Mike? I've met this person 10, 15 times and I didn't know this. And the answer is listening, allowing time to chat. Sometimes what seems to be not very pertinent and useful can turn out to be really pertinent and useful in the end because you build up that rapport, and that's where they'll tell you more things that they wouldn't tell somebody else, perhaps.
Great. And then another comment here. I was just thinking about going through PT school 20 years ago. I'm not sure if it's changed now, but it seems like the way we train PTs sets the stage for how they communicate and view patient interactions.
Some and some. I think it varies really. Some PT schools that I've been into have a real focus on this type of work, and they concentrate on getting their students to consider what they're saying and the impact of the words that they have. But not all. I think there's still some work to be done there. Yeah, sadly, I think those words of Rudyard Kipling still ring true over 100 years on.
And another question from Angela here. For chronic pain patients, how do you suggest counseling if you think that is a route they would benefit from?
I'll try my very best. I'll try to make sure that they bring up that subject. So, has it been helpful to talk about this today? Often patients will say, "Oh, I feel much better," but we haven't really done anything. We've just had a chat. We just seem to talk. So then that's a sort of in a sense. It's a door that's left wide open to say, "Well, would it be helpful to talk more about this?" Am I that person who's going to be helpful, or would it be helpful to talk to somebody who's more professionally qualified in this field? So I think it's important to allow them to approach the subject and sometimes wait for those moments where they will highlight and reflect on the benefit of talking.
Great. Should we get into the game?
Yeah, by all means. Yeah. So we have a game. This is called the communication game, collaboration game sometimes. And it goes a little bit like this. We play this with patients sometimes, and I think some of the things that we've been talking about in the webinar today are highlighted quite nicely in this game. We can talk about that maybe afterwards. We're going to play the game twice. I have two pieces of paper in front of me. In the first part of the game, on the piece of paper that I have in front of me, I have four shapes. I'm going to describe these four shapes, and I would like you to draw these four shapes on your piece of paper. Now, there's a problem here. You're not able to ask any questions in this first part of the game. So it's just me talking, me describing, and then you following my instructions. You've just got to draw what I ask you to draw. And the idea is, hopefully, we should have a perfect mirror image. So if you can turn your cameras on in a minute, I should be able to see a perfect mirror image to the four shapes that I have in front of me. And just a word of warning, the person who gets the most similar, the closest to what I've got on my piece of paper, is going to be the person who wins a free place on our next course together in the fall. So good luck, bon courage. So I have four shapes in front of me. Now this is easy for me because I know what these shapes are, so I'm not going to spend much time describing this. The first shape is a circle, and then you've got another circle within that circle. And then the next shape is a large diamond. The third shape is a heart. And the fourth shape is a cross. So I'll just recap over that again because I went a bit quick. But this is what we do in healthcare communication. We rattle through information quickly, often with lots of other distracting noises taking place in the clinic. So, okay, just to be fair, we have a circle with another circle inside. We have a diamond. We then have a heart. And then finally, we have a cross. Okay, so if you'd like to turn your cameras on, let's see who's got closest to what we should have, which is this. These should be these four shapes that we have. Now, of course, my curse of knowledge, I know these shapes really well. I know the orientation of the paper. I know, nope, ha ha ha, says Melanie. This is tricky. Oh, Angela, you've got something there that looks, you've got the four shapes I can see, Angela. They're not just quite in the right position. That's fair enough because I forgot to do that because this is what we do with healthcare communication. We get to know something so well that we forget that our patients don't know anything about it. So we don't give them any reference points. This is the curse of knowledge combined with ambiguity. Oh, Lorraine's looking quite good there. Catherine, can I see yours again? Yes. Do you know, I'm going to give it to Angela. I think Angela, you've got the four shapes. They're not in the right order, but then that's my fault, not yours. But the shapes look pretty decent in terms of size. They're pretty similar. So congratulations, Angela. I shall see you in the fall. Can we now play the game again? So I've got another four shapes. But what I would like you to do this time is I want you to ask questions. I want you to clarify. So this is going to be a collaborative two-way communication. So again, I have four shapes in front of me. What would you like to know first of all? Any questions about these shapes? Please unmute yourself and ask.
It just takes me a moment to give everybody their mics. So
It's all right.
sorry, that's my bad. Everybody should be able to unmute themselves now.
So we have four shapes. The first shape that we're going to start with is a square. So what would you like to know about the square?
Is it perfectly angled?
It is. The square is a perfect square, and it's at the top in the middle of the piece of paper. Anything else you would like to know about the square?
What's the size of the square?
Ah, great question. It is, now you're asking a man about size, so I'm not going to be completely accurate, but it's probably about 9 centimeters, maybe 10 centimeters at most by 10 centimeters.
Is it empty?
Oh, great question. It is empty. It's just an empty 10 centimeter by 10 centimeter square that sits in the top and the middle of your piece of paper. Are we ready for the second shape? Okay. The second shape is a circle. What would you like to know about the circle?
Where is it?
Aha, good question again. The circle sits beneath the square and slightly to the left. So it just sort of touches the 12 o'clock point on that circle. If it was a clock, where the 12 o'clock is at the top of the circle, just about touches the bottom left-hand corner of the square.
Is it big?
Same size, very similar in size to the square.
Empty?
Empty again, nothing inside. So let me recap again. We should have a square, about 10 centimeters at the top in the middle. And then underneath and slightly to the left is a circle, which is a similar size to the square. And it just touches the bottom left-hand corner of the square where the 12 o'clock would be on that circle.
Does it intersect?
No, it just meets that bottom corner, but it doesn't intersect. It doesn't go inside the square. Okay, third shape. This time you're going to draw a right angled triangle, and probably the best way to draw this would be to start at where the 5 o'clock point is on that circle and draw a straight line down the page. And then you're going to go out to your right hand side. So it's a triangle that goes out to the right. Would you like to know anything else about that triangle?
What
Is it
is the
also
size?
similar in shape or size,
No.
sorry?
What size? Similar size again to the other two shapes above. So
Does that intersect?
no, again, it stays outside the circle. So the very, very tip, the top tip of the triangle just about touches the 5 o'clock point on that circle. And then it goes down and then out to the right hand side at a right angle, and then it joins back up again to where you started to make your three-sided triangle.
Mm.
Moo. That's the noise of ambiguity. Okay, finally, the last shape. We're almost there. This is the hardest shape, I think. It sits underneath the triangle, and it's a sort of six-sided squashy hexagon. What would you like to know about that? That's my best effort.
Where does the top part of the hexagon fit under the triangle? Is it in the middle or is it off to a side?
It's just where that right angle is. So that sort of, the bottom left-hand corner of that triangle that forms the right angle, it sort of sits there. The top of the hexagon joins. It becomes almost one. It's seamless. Anything else you'd like to know about this hexagon? Okay, I think we should have. Shall we see how well we've all done? If you turn your cameras back on, this is what we should have. Hang on, I'll just get rid of the one behind it. That's what we should have if our communication has been anywhere better. Can you turn your cameras on and show me what you have? Is anybody feeling more positive about this? Better than the first result?
Okay.
Yeah, pretty good. I can see some, yeah, okay. There's some slight differences, but certainly sort of a little bit more precise than what we did first time round. So,
I think I was doing better at first, but I changed later.
oh, yes. Yeah. What does this mean? What's the take home message then? What would you say? You've just played a game with some shapes, and we play this sometimes with patients. But so what? What does this all mean? What have you learned that you're going to change about how you communicate with patients in your clinic?
So kind of like differential diagnosis, like kind of giving a little bit of uncertainty, but like I do have a bit of idea of like where we are heading to.
Good, great. Yeah, yeah, there are lots of different ways that you can take this, So that heart, for example, I've asked people before, I've said, can you draw a heart? And then somebody will draw an anatomical heart with ventricles and an aorta rather than a cartoon heart that we drew in the first one. So we see this all the time. Patients will often become confused because, of course, we know things that we forget we know. We know words like patella, and I've even forgotten that my patient doesn't know what the word patella is. She said, "What is a patella? I've got a Spanish rice dish inside my knee." I was like, "Oh no, no, not a paella, a patella." She said, "Well, why do I have one of these in my knee?" I said, "Well, it's it's the kneecap." "Oh yeah, I know kneecap." But we forget the jargon that we use in healthcare becomes so intrinsically part of what we talk about that we forget that the patients don't really know these things. So we have to check and clarify back on ourselves, I think. So thanks very much for playing that game. I hope it was fun. And think about how you could use that with patients and also reflect on what it means for your communication with patients in clinic.
Wonderful. Well, thanks, Mike. Fun hosting you as always. And for those interested in uh, taking a full weekend course, which is similar to this past 40 minutes that we spent together, except for 2 full days with Mike. He will be joining us in November for his weekend course. So if you're interested in that, I'll put the link in the chat here. And Angela, I will email you afterwards with how you can register for free. And we hope to see many of you there. I think we'll close out for today. Thanks everyone for joining us. And if you wanted to share this recording, or if you thought maybe you have a colleague who'd be interested in watching this or could benefit from watching this, you can find it on YouTube or a course on Embodia. So either spot, you can go and watch that for free, or you can share it with your colleague. And I'll include those links afterwards in a follow-up email. Thanks, Mike.
Fabulous.
Hope you have a good
very
evening.
much. Thanks, Maggie. Thanks for inviting me, and thanks everybody for taking the time to listen. I hope you found it helpful, and I hope to see you again in the future.
Yeah, wonderful.